Okay, now we'll be starting regarding the metabolic complications associated with the prematurity. First, in this, there are actually three important things. First is actually infant of diabetes mellitus, next is hypoglycemia, and next is hypocalcemia. In case of infant of diabetic mother, see, firstly, in an infant of diabetic mother, the mother will have maternal hyperglycemia, see, which in turn usually leads to fetal hyperglycemia. Since in the fetus, the glucose level is usually more, there is increased production of insulin in the fetus, leading to fetal hyperinsulinemia. Always maternal glucose will usually cross the placenta, but the maternal insulin does not cross the placenta. See, in infant of diabetic mother, there are fetal hyperglycemia and fetal hyperinsulinemia, which are responsible for all the complications of infant of diabetic mother. Now we'll be going effects of fetal hyperinsulinemia. Major hormone which is responsible for intrauterine growth of baby is actually insulin. Therefore, hyperinsulinemia causes LGA or macrosomia. Since the amount of insulin in the fetus is more, obviously it will usually cause fetal hypoglycemia, and this hypoglycemia will cause seizures. Increased insulin in the baby prevents the parathormone release in the baby. The parathormone, since is absent in the baby, it will leads to low calcium level, that is hypocalcemia. See, hypocalcemia in the baby can also cause seizures, but the most common cause of seizures in the baby is hypoglycemia. And insulin is also associated with increased insulin is associated with polycythemia. This polycythemia occurs due to hypoxia and extramedullary hematopoiesis. This polycythemia in turn causes neonatal jaundice and increased incidence of thrombosis like renal vein thrombosis and cerebral vein thrombosis. Increased insulin will usually cause cardiomyopathy. Most common finding in the infant of diabetic mother is cardiomyopathy, and also it is also causes increased insulin also causes hypertrophic cardiomyopathy. This hypertrophic cardiomyopathy will have a spontaneous resolution, that is no treatment is required for the hypertrophic cardiomyopathy. And next, insulin is antagonistic to cortisol. See, always insulin is opposite to cortisol release, which in turn this cortisol is responsible for the surfactant production. That is, cortisol is responsible for the surfactant production. Therefore, in hyperinsulinemia cases, there is no cortisol production, leading to absent surfactant or the delayed surfactant, which in turn causes absent or a delayed lung maturity. All these are actually related to all sorts of fetal hyperinsulinemia, fetal insulin effects on the baby. Next, we'll be going for what is known as effects of fetal hyperglycemia. Mainly usually causes defect in the organogenesis. Overall, most important specific defect is sacral agenesis, which is also known as caudal regression syndrome. Overall, most common system affected is actually the cardiovascular system, and most common congenital heart disease seen in the infant of diabetic mother is ventricular septal defect, and most specific congenital heart disease is transposition of great arteries. Next, we'll be going for what is known as small left colon syndrome. It is rare anomaly which develops in the second or the third trimester because of rapid fluctuations in the maternal and the fetal glucose. This leads to impaired development of left part of colon, leading to impaired motility and impaired intestinal growth. All others like sacral agenesis, VSD, TGA will usually occur during the first trimester. And next we'll be going for what is known as hypoglycemia. Neonatal hypoglycemia. See, it is actually that of the blood glucose level which is actually less than 45 milligram per deciliter as per WHO. Screening for hypoglycemia is recommended in the following high-risk infants. The high-risk infants include prematurity, that is less than 35 weeks, birth weight which is less than 2 kgs, and small for gestational age babies and large for gestational age babies. And next we'll be going for what is known as IUGR, and next we'll be going for what is known as infant of diabetic mother and conditions like Beckwith-Wiedemann syndrome and congenital adrenal hyperplasia, and sick neonate like hypoxic ischemic encephalopathy, neonatal sepsis, hypothermia, and RH hemolytic disease. Mothers who are usually taking drugs during the pregnancy like plot and propanolol, labetalol, oral hypoglycemic drugs, terbutaline. Any incidence of family history of genetic form of hypoglycemia, neonates on the parenteral nutrition. Later on, we'll be going for what is known as clinical features of neonatal hypocalcemia. Earliest presenting feature is jitteriness. In case of prolonged hypoglycemia, it would lead to occipital lobe epilepsy. Next, we'll be going for what what is known as frequency of blood sugar monitoring. In case of sick neonate, every 6 to 8 hourly will be going to measure the blood sugar levels. At risk infants, that is remaining all conditions of screening of hypoglycemia except the sick neonate done at 2 hours, 6 hours, 12 hours, 24 hours, 48 hours, 72 hours after the birth. Therefore, 4 times on the day 1 and 2, 6, 12, 24 till 72 hours after the birth is a last time monitoring. Next, we'll be going for what is known as management of neonatal hypoglycemia. We'll be going to check for that of the blood glucose. If the blood glucose is less than 45 milligram per deciliter, then check whether the patient is asymptomatic or symptomatic. First, asymptomatic anmata. If the blood glucose level is 20 to 45 milligram per deciliter and if the blood sugar level is less than 20 milligram per deciliter. If the blood sugar level is 20 to 45 milligram per deciliter, then give oral feeds, that is insert the nasogastric tube and usually start giving expressed breast milk. Next is to monitor that of the blood glucose after that of 1 hour giving that of the oral feeds. See, if the blood sugar level is greater than the 45 milligram per deciliter, then give frequent feeds. If the blood sugar level is less than 45 milligram per deciliter, then you will be going to give what is known as IV glucose infusion at the rate of 6 mg per kg per minute. Increase till the glucose infusion rate is 12 mg per kg per minute, which is maximum. If still not controlled, then go for hydrocortisone, diazoxide, glucagon and octreotide. If the blood sugar level is less than 20 mg per deciliter, then give IV glucose infusion at the rate of 6 mg per kg per minute and increase till the glucose infusion rate is 12 mg per kg per minute maximum dose. If still not controlled, then you will be going to go for hydrocortisone, diazoxide, glucagon and octreotide. If the patient is symptomatic, then you will be going to give a loading dose of 10% dextrose 2 ml per kg followed by IV glucose infusion at the rate of 6 mg per kg per minute, which is maintenance dose, and increase till the glucose infusion rate is 12 mg per kg per minute, which is actually maximum. If still hypoglycemia, then you will be going to go for hydrocortisone, diazoxide, glucagon and octreotide. అది అయిపోయిన తర్వాత నెక్స్ట్ in case of small for gestational age, diazoxide or the glucagon is not used. You should know what is golden minute of life and what is golden hour of life. Golden minute of life అంటే first 1 minute after the birth, where a neonatal resuscitation program is actually well suited, and next is actually golden hour of life is actually where resuscitation, where it is not at all related to resuscitation, but it is related to idi, that is feeding anamata. Irrespective of whether the baby is born through the normal vaginal delivery or C-section, always you have to give idi. Next will be always you have to give feeding within 1 hour. Next will be going for what is known as neonatal hypocalcemia. See, in case of term child, total serum calcium is less than 8 milligram per deciliter and ionic serum calcium is less than 4.8 milligram per deciliter. In case of preterm child, the total serum calcium is less than 7 milligram per deciliter and ionic serum calcium is less than 4 milligram per deciliter. Neonatal hypocalcemia is of two types: early onset hypocalcemia and late onset hypocalcemia. Early onset hypocalcemia, it usually occurs within 72 hours of birth. It can be usually seen in preterm infants born 32 weeks of gestation, infant of diabetic mother, perinatal asphyxia, iatrogenic, that is any condition which causes alkalosis. And next will be going diagnosis of early onset hypocalcemia. ECG will be going for what is known as QTC interval and Q0TC interval. So if the QTC interval is greater than 0.45 and Q0TC interval greater than 0.22, will be going for what is known as calculation of QTC anamata. QT interval in seconds divided by RR interval in seconds square root anamata. See, later on will be going for what is known as Q0 TC calculation. See, that's you have to know. Treatment of early onset, see here the QT interval in seconds is usually calculated from the beginning of Q wave to the end of the T wave. Here Q0 interval in seconds is usually calculated from the beginning of Q wave to the origin of the T wave. And also we'll be going to find out the serum calcium level. Treatment of early onset neonatal hypocalcemia. See, if symptomatic, you will be going to give 2 ml per kg IV 10% calcium gluconate, which is actually loading dose, followed by 8 ml per kg per day 10% IV calcium gluconate equivalent to elemental calcium 80 mg per kg per day for 48 hours, followed by 10% calcium gluconate IV 4 ml per kg per day for 24 hours. Here both B and C are actually maintenance dose. If still asymptomatic, then you will be going to give 8 ml per kg per day 10% IV calcium gluconate, which is equivalent to that of elemental calcium of 80 mg per kg per day for 48 hours, followed by 10% calcium gluconate IV 4 ml per kg per day for 24 hours. Here only maintenance dose is usually usually given for 72 hours. Next, we'll be going for what is known as late onset hypoglycemia, which is seen after 72 hours of birth. It can be due to decrease in level of PTH, vitamin D deficiency, and increase in serum phosphorus. First, a decrease in level of PTH causes include absence of parathyroid gland, which is seen in Dijot syndrome, and maternal hyperparathyroidism during pregnancy. Where there is maternal hyperparathyroidism during the pregnancy will lead to maternal hypercalcemia, which in turn causes fetal hypercalcemia, which in turn causes decrease in PTH. Next, we'll be going for what is known as vitamin D deficiency. Causes includes maternal vitamin D deficiency and vitamin D metabolic disorders like vitamin D deficiency, rickets, 1A, 1B, 2A, and 2B. Increase in serum phosphorus. When there is increase in the serum phosphorus, there is decrease in the serum calcium. Causes include acute renal failure, cow's milk feeding baby anamata. In cow's milk, calcium to phosphorus ratio is less than 2. Then it will lead to more phosphorus absorption, which in turn causes decrease at calcium level. See, no baby up till 1 year of age should be usually given cow's milk. And see, that is give only after 1 year. Treatment of late onset hypocalcemia. Initial treatment is same as early onset hypocalcemia. This should be usually followed by specific management according to etiology. And now we'll be going, this whole sorts completes the metabolic complications. So in short, we have done with infant of diabetic mother, wherein we have gone with basic introduction, and next we have gone with effects of hyperglycemia and hyperinsulinemia, and later on we will be going for what is known as hypoglycemia, wherein we have usually gone for definition, screening, clinical features, and later on we'll be going for what is known as frequency of neonatal blood sugar monitoring, and finally we'll be going SAF, and finally we'll be going for what is known as management. And now we'll be going for what is known as neonatal hypocalcemia. In case of term child, what happens? In case of preterm child, what happens? And next, we'll be going in detail regarding early onset hypocalcemia and late onset hypocalcemia, definition, causes, diagnosis, and treatment. This was whole sort done with your metabolic complications of prematurity.